we are losing the PR battle. Radiologists are losing the PR battle. We are not educating our patients as to what we do.
Welcome to RadCentral, a radiology podcast hosted by Excalibur Healthcare. I'm Laura.
I'm Betsy. Let's get right into this episode's topic. It is about scope of practice expansion. This is a very contentious topic, and the importance of all professionals and their contributions to the delivery of healthcare can't be understated. Our intent is to speak objectively and factually, and we have no intention to disparage any contributors. So another thing we want to cover before we have our interview is we want to tell the audience that we intend to use the acronym NPP, a quick acronym to stand for non-physician practitioner. So this term can refer to a number of healthcare professionals. They include physician assistants, nurse practitioners. It can also include certified registered nurse anesthetists. So we will be using NPP as our standard acronym for non-physician practitioner. Scope of practice expansion, what is it? Well, scope of practice expansion gives NPPs the ability to perform more services that were previously only in the realm of physicians. So this is something that is accomplished through state legislation where they're given the ability to perform more tasks, and they are legally allowed to do so. So let's get right to the interview.
We are delighted to have our guest with us today to share her perspective on the effects of scope of practice expansion. She comes from a long line of radiologists with a vast knowledge of radiology in the private sector, academics, and changes in radiology as we see them today. She is a well-respected physician and distinguished professor in Los Angeles, California, with multiple publications in the RSNA Journal of Radiographics, Wiley Online Library, and Springer Link, and recipient of the Outstanding Clinical Department Award. A lifelong procrastinator, baker, traveler, and hiker, let's welcome the Associate Clinical Professor and Vice Chair of the Department of Radiology at a top-ranking educational institution in Los Angeles, California, Dr. Monica Deshmukh. Welcome.
Yay.
Hello, thank you for having me. Thank you so much for having me. I'm very excited.
Thanks for coming. Of course, yeah. So we're delighted to have you on our show. Is there anything you would like to add to your very impressive resume that I just went through?
I mean, no, I think that you said everything perfectly. My mom would be so proud. Yes, I grew up around radiology. And so I actually have the unique distinction of seeing how it has changed so much from the days of fluoroscopy, ultrasound, X-ray to advanced imaging, AI. And I'm really excited to share my perspective with you guys.
Wonderful. Yeah. So that leads me to my next question. Why radiology?
Yeah. You know, it's so funny because, like I said, I grew up in and around radiology. I genuinely, was very undecided when I attended med school. But after going through all of the rotations and learning about the different fields, I really got very excited about radiology. I was lucky to have some really great mentors. And that's one of the most important things about medicine is latching on to good mentors. And these actually predominantly female physicians really shaped my worldview and made me excited to practice. Radiology is a very unique field because it's not what people typically think about when they think of medicine. You know, they think about TV shows, they think about the emergency room and coding patients and traumas. It's a little more what I like to call cerebral. And that's something that really attracted me to it. Also, I'm very interested in the role of medicine and technology. Medicine, what is it going to look like in the future? And I think radiology is a perfect field to kind of address those issues. So those are sort of my main instances, my main reasons.
Yeah, perfect. Yeah. So, Betsy, you want to take it?
Sure. And we have some questions for you,
Sure.
Particularly about the topic that this episode is about, and that is scope of practice expansion. And I want to start off with a question. Have you or your colleagues experienced scope of practice expansion within your own work environment? And can you tell us what that might look like in your experience, or anecdotes that you've heard from your radiologist colleagues? We're particularly interested in the radiology specialty and scope of practice expansion. It's
Uh,
something that's happening with lots of specialties.
Right.
We want to talk about radiologists.
Absolutely. So we are very blessed. We do work with excellent nurse practitioners, but they are mainly in the fields of interventional radiology. So our nurse practitioner, she is a part of the team. She works up our patients. She screens the referrals and determines which studies should be worked up, which studies warrant interventional imaging, interventional, should this be seen by the physician? She is an essential part of the service. As of right now, we do not have NPs or PAs in the diagnostic realm. However, as I practice in the state of California, there's been a lot of new laws. And one of the most important laws that I think we should discuss is the law called California Assembly Bill 890. It was just passed in 2023. And this bill allows nurse practitioners with 3 years of experience to apply to become independent. Previously to 2023, most NPs had to work under the guidance of a physician, with some notable exceptions like the emergency room, women's health, etc. So this is expanding it much more globally. So as of today, we are mainly working with NPs under physician guidance, but the future is going to be very different. And I think that's something that we need to focus on and talk about and educate the listeners about. What's the future going to look like?
Sure. Is this bill, the research I've done on scope of practice expansion is that these additional privileges or additional, correct me if I'm using the right vocabulary, scope of practice bills, when passed, typically go into effect either immediately upon passing, or there is some kind of additional training requirement set into motion that when the bill passes, they need to be able to get this training to have those extra expanded scope of practice. So
Correct.
can you explain to me what
Sure.
that particular bill will
Sure.
have when it goes into effect?
Absolutely. And one thing I want to say before I delve into that is that for the listeners, all of this is on the ACR website. So if you just Google ACR scope of practice expansion, there's a tremendous amount of resources. Most of the education that I am receiving about this topic is coming from these resources and the AMA. With these bills, absolutely, there is a minimum requirement of hours. At least this is for my state. So my understanding, and I could be off a little bit with the numbers, is 3,000 hours is what's required before you can apply for this new licensure. And it is called an NP3, it's called an NP 103. This is a designation which allows an NP to practice without physician supervision. But a physician needs to be available for consultation. So they need to have access to a physician. There's a second tier called an NP 104, which will allow the NP after 3 years of being a 103 to be completely independent. Okay? So this is where things are going. There's multiple states that already allow NPs to essentially be independent. But the reason why I'm bringing up this bill is because one of the things that was introduced but was defeated by lobbying by the ACR is allowing NPs to not only order imaging, but perform and interpret imaging. That provision was killed. And that is very good. So without that provision, with 3,000 hours of experience, an NP could start interpreting images.
Yeah.
Oh,
Yeah.
what's to give us a comparison? What does that look like compared to a radiologist's hours of training? What's
Huge
how?
difference. So
Okay.
for the listener, again, this is going to be on the website. A radiologist has to go to medical school for 4 years. We have to do an internship and we have to do a 4-year residency. Then a majority of radiologists then do a fellowship, which will vary in size from 1 year to 3 years. That is multiple years of training, multiple years of debt.
Mm-hmm.
So our experience is vastly different than a nurse practitioner and a PA. Again, I'm not discounting the role. I have a tremendous amount of respect for the nursing field in general, particularly after what we've dealt with COVID. These are essential members of the workforce in healthcare. However, it is very important for physicians to be able to distinguish ourselves from an NP and a PA. And another thing we should discuss is there's nomenclature changes, coming, where, for example, in the state of Colorado, PAs, physician's assistants, are called physician's associates. In other states, nurse anesthetists are going to be called doctors of nurse and anesthesia. Like, these changes can be very confusing to our patients. And this is why I tell my residents and I tell my trainees that we should avoid using the term provider. We are not providers, we're doctors. I think it's important that we use appropriate nomenclature to distinguish ourselves. A provider is a generic term. I respect the term provider. That is a term that we use often in my facility, but we're doctors.
Mm-hmm.
And I think it's important to make those distinctions.
Yes.
Certainly.
Do you think that the change in the nomenclature is intentionally trying to confuse the public?
I think that we have to be careful. I don't think anybody's trying to mislead, but I do think that it allows interpretation. It expands interpretation. And
mm-hmm.
I think, for example, if your average patient is not educated as to the different roles of providers versus physicians, they may be confused. And I am, again, I'm not discounting the role of PAs and NPs, but I think there has to be a distinction. And I don't want to use the word confusing, but I think it could, I think that's the slippery slope it could go down, to be honest.
From the public's perspective, I'm very new to medicine and
Sure.
the culture of medicine and the nomenclature, as you've mentioned. So from the public's perspective, it would be confusing. I would not know who a physician's assistant versus a physician's associate would be.
I agree.
Right.
And I think that, right now we are dealing with global healthcare and healthcare worker shortages. Mm-hmm. We have, in fact, at the RSNA, they talked about it as one of the biggest issues affecting radiology today. And we have to be very cognizant of this, because right now, I think back to just going to the doctor myself. I was told for my own physician, I had to see somebody new because my primary care doctor, she retired. Mm. And they told me to see a new doctor, I had to wait 3 months, but I could see a PA in a week. And I said, I'll see a PA in a week. That's fine. We had the appointment and, I respected this person. I really appreciated that I was able to be seen so quickly, but there was a distinction in care. I think that we have to be very careful. These are different. These are apples and oranges, and there has to be a maintenance of that distinction to the public.
Right. And so with the changing as it stands for radiology, and the changing roles of the physicians and the NPs and the physician assistants, can we talk about the rise in unnecessary imaging mm-hmm. that's been connected to NPPs? Have you seen that in your practice?
I have. I work pretty extensively with NPs in the emergency department, and I do a lot of emergency radiology. And they are, they're mainly working in triage. So they triage the patients and they're ordering imaging. And it's pretty routine for them to order a significant amount of imaging. Now, would that be, I'm in a teaching hospital, full disclosure. So would that be different from a resident physician? I don't know. But in non-teaching hospitals, I would assume the answer is yes. And some of the data does back that up, that these providers are increasing healthcare utilization, increasing advanced test ordering, and increasing the number of tests that that need to be provided and need to be performed. If you don't have a wide, vast array of medical knowledge, you are going to order more tests. I think that's pretty, self-explanatory. If you don't really know what's going on, you have to order more imaging, you have to order more laboratory and more specialized care, see a specialist rather than figure out what's going on as a physician on your own. And I think that's something that we will have to grapple with. And maybe that will offset the sort of explanation for why we are using more NP and PA services, which is cost, right? They cost less. But if they are ordering more and they're overall increasing healthcare expenditures, what is the trade-off?
Not to mention, I would think that in an emergency department, ordering images because you're not able to make a quick diagnosis can affect the delivery of care timing-wise.
Absolutely. I think it would
Okay.
will prolong your stay. But we also have to remember there is, like I said, a physician shortage. They are dealing with a lot of, we're dealing with a lot of patients in healthcare right now. We are seeing that sometimes the demand of patients exceeds the supply of physicians. So again, there is a role for providers like NPs and PAs. However, maybe if ordering these imaging studies and then having a physician decide, okay, this is appropriate, this is inappropriate, may be better utilization of services. That being said, that being said, we also need to be very careful and mindful that we are not increasing this workload for physicians, because there is a lot of, anecdotal stories out there about, for example, in anesthesia. One physician anesthesiologist is overseeing multiple nurse anesthetists, and how is that safe? So I think it's a very fine line, and it's kind of uncharted territory. And so we have to be careful.
Can I ask a patient question?
Sure.
As a layperson that has the ear of a radiologist, can you tell me what does supervision mean when someone is when NPPs are being supervised by a physician?
Sure.
What does that look like? And anecdotally, when I'm seen by an NPP for a routine physical or something like that, even if I'm under the understanding that they are being supervised by a physician, as the patient, I don't see that. I don't see where the physician's supervision is coming from.
Yeah.
I don't know. The definition of supervision is foggy to me.
I think that, in an ideal world, we're talking an ideal world, the physician is developing a relationship, establishing standardized practices, overseeing the NP and the PA with a high degree of oversight in the beginning, for example, when they first start at the clinic, and seeing them interact with patients, making sure it's appropriate and it's within standard of care. And then I assume in primary care, I can't speak for that, then further allowing them to have more autonomy. But at the end of the day, co-signing their notes, co-signing their orders, and ultimately taking their liability, correct? Because, the physician would have ultimate liability over their staff. That's in an ideal world. I think where things can get slippery is if there's less supervision because of these increasing number of patients and the amount that physicians are getting stretched thin. But that would be in an ideal world. In radiology, and I'm speaking about interventional here, we oversee pretty significantly. There is the NP in our practice does mostly triage and management lab assessments, making sure the INR and the PT and the labs are appropriate to do the procedure. She is not doing the actual needle pokes, anything like that. That varies. Other institutions, they are doing ports, they're doing PICC lines, they're doing other types of procedures and being overseen by a physician. So I think it really varies. But in an ideal world, we want to believe that they are being managed and supervised in the beginning so that they meet their standard of care. And then the physician is allowing them to do stuff without sort of like hovering and then co-signing their notes and co-signing their orders.
And the physician is ultimately responsible.
Precisely. In these, yes, when the NP or PA works for them, correct, because they need to stick within the guidelines of their standardized procedures. So remember, an NP and PA can independently do things within the scope of their standardized procedures.
Okay. So can we talk about some alternative measures that might be considered to reduce inappropriate scope of practice expansion?
This is a tough question because I will be honest, and this is what I want the listeners to know. This is coming, okay? Especially in radiology. This is coming. There is two areas where we need to be careful, and that is for-profit hospital systems and this is going to be, I think, a different topic on the podcast, is investor-owned practices, correct? Practices owned by non-physicians.
Yes.
This is where really, and before we talk about that, I kind of just want to talk about the history of this, because I think it's important for people to know. So, NPs and PAs, the fields were actually created quite long ago in like the 60s or something as adjuncts because of the increased demand on physicians. It wasn't really until the 2000s where the scope of what an NP and a PA does truly expanded, and it's for a few reasons. Number one, we have to talk about resident work hours. So when the resident work hours changed, from residents could basically be abused and work, 100 hours a week and 110 hours a week. That changed. And they were then allowed to, basically residents are not allowed to work 80 hours, more than 80 hours a week. Where is that extra work going to be absorbed? This is where NPs and PAs filled that void. That was number one. Number two, I'd like to talk about the ACA. The Affordable Care Act was administered in 2010 and was passed in 2010 to increase healthcare access. And NPs and PAs were realizing at that time, we need to start lobbying our government to allow us to be part of that equation. And then finally, in COVID. COVID is really where these expansions really dramatically increased. For example, the VA. The VA basically, rapidly expanded the scope of practice for NPs and PAs during COVID because they had to address the massive demand of patients that they needed to see, and the physicians couldn't supervise all of these PAs and NPs. And then there was executive orders where all supervision of NPs was dropped, for example, in New York during the height of COVID. So those were really the areas where this became dramatically increased. And lobbying efforts on behalf of NPs and PAs were really dramatically increased. Luckily, the ACR and the AMA were able to keep up with this. But I think that we are going to start really struggling in the future. And the reason why is because now we have a lot of investor funded private equity, venture capital, and retail, services like big corporations that are moving into medicine. And with their movement into our field will be a dramatic expansion of lobbying efforts to create more positions for non-physicians. So I think it's really important that we realize that this is something that the future is very uncertain. And I'm not trying to scare people. I'm just trying to educate people to the realities of what we face. And
Certainly.
yeah.
I really appreciate you talking about this. I think this is a great topic for a podcast, because when I talk about it at the dinner table or bring it up with my parents or my friends,
Yeah.
you can start a conversation with, do you know what scope of practice expansion is? And they say no, they don't know. And then as soon as I explain it to them and connect it to how they've experienced going to see their primary care physician, or they've needed a procedure done, as soon as I explain what's happening, of course they immediately have a story to tell. Everyone has experienced this in some way recently, if not multiple times, and I'm a little amazed that it's just behind a thin wall that people don't understand that it is a big issue, and it's affecting them already.
And I think that's where, as physicians, we're not doing our jobs of education.
You're busy.
We're busy, but we are losing the PR battle. Radiologists are losing the PR battle. We are not educating our patients as to what we do. I was, as we had discussed when we first connected, something like 50% of Americans don't even know that a radiologist is a doctor. We are not doing enough to educate people about what we do, about what physicians do. We are losing the PR battle. And this is where one of the most respected professions in America is nursing, not physician. And there's a reason, because I genuinely respect. I remember when I was, having my own, having various healthcare challenges, the role that nurses play is essential. They are so patient facing. There is also a belief that NPs and PAs spend more time with you. Physicians are too busy because they're always writing down notes and they're always, checking their phone or checking their watch. We need to change patient education so that they trust us more with their care. And then they demand to say, you know what, I want to see the physician. And that's really where we have to be involved in lobbying, PR, legislation.
Yes, and that's something that we talked about before we started interviewing you, that it is a state-by-state thing, and you were talking about the ACR, the AMA is also they have a great website. It's very public-friendly, and you can read it, and there's a lot of ways for anyone to understand what's going on and let their legislators know that they're concerned about still having physicians be part of their care.
Absolutely. Absolutely. And to circle back and address what you had discussed, how can we prevent this for the future? And I think that there's a few areas. Number one, we have to increase the number of doctors in this country. American doctors trained in the United States. Again, I'm not discounting doctors outside of the United States. They're fantastic, but we need to train more physicians in America. We need to expand the number of medical schools. We need to expand the number of facilities to deal with this. We need to expand our residency programs. We don't have residency programs are funded by the federal government, by Medicare and Medicaid. There are more medical student graduates than there are residencies. We need to expand residency programs. We need to reduce the barriers to medical education. It is very challenging to become a doctor. I don't know how I became a doctor. I look at some of our medical students and I'm like, wow, you guys are, from just incredible resumes. And I commend them, but do we need that? Like, can we make things easier for people? Can we make it so that, hey, I'm an MP and I want to go to medical school. Can we make it so that, maybe People that have been in practice in other fields for a few years can transition and can become physicians. We have to lower the barrier. That's number one. Number two, we have to embrace technology as our friend. We can't be afraid of technology. There is really, really cool stuff out there that's going to help radiologists become more efficient and faster and more accurate. And we have to embrace that. We can't run from it. It's not going anywhere, and we don't want it to replace us. I think that's what has to happen. It's essential. And I always, tell my students and my residents that we have to be involved. Serve on your professional association at the hospital. Go to your tumor boards. Be friendly. There's sometimes a misconception that radiologists are just like trolls living in the basement. We're not. We're really nice people. Come visit us. Come see, your patient's imaging. I love Teams. I love, this is not a plug, but I love, anything remote that's patient friendly, that protects HIPAA. Show them images online and be available. We need to make sure that we are a part of the team. Otherwise, we will be replaced. That's how I feel.
Excellent. Yeah.
I'm very passionate about this because I think it's just, I think that, that physicians we are losing our legislative battles. We need to be more involved in legislation because there are people that will fill the voids for us if we're not.
I was listening to some other podcasts that were related to scope of practice expansion. We are going to put them in the show notes. There's some great information that can help not just people involved in medicine for their jobs like us, but if anyone's a patient, and I know there are some patients out there, they would want to educate themselves on how they can advocate for getting seen by physicians.
Mm-hmm.
We want to help you become more visible.
Absolutely. Mm-hmm. And I also think that, one more thing, not to keep referencing it, but there are funds available. If you go on websites like the AMA and the ACR, they have grants that state societies can apply for to lobby against these efforts. So you shouldn't feel like there's not resources available to you. You can have those resources. And again, going on the professional society of your hospital and voicing your opinion as to how you feel about these practices could be very helpful. We, again, with the rapid expansion of non-physicians in healthcare, we can't lose our voice.
It is important to mention that this is not an American problem because someone who is not paying that much attention might dismiss this as an American problem. Scope of practice expansion is being implemented in other countries as well, the UK being one of them, and they're not having, it's not good. They're having problems as well. I won't speak directly to the details of their issues, but we will have links in the show notes if anyone's interested.
Absolutely. I'm glad you brought that up because the UK is going nuts. I mean, and they're publishing. That's the thing that's concerning, is that they are doing these changes, making these changes, and they're rapidly expanding scope of practice for, especially in radiology, and they're publishing their data. And that is where we become vulnerable because we are relying on our stories and our experiences. But when there's data out there, that's when legislators who love numbers, they love to crunch data, show me the data, will say, but wait, it's okay because they did 10,000 patients in the UK and everything was fine. And the reality is it's apples and oranges. Remember, the UK healthcare system is extremely different from the United States, completely different. And, we need to protect our patients, and we need to understand that these studies are coming out, and we don't want to become the UK. I don't think our patients want us to become like the UK. And that's a different topic of conversation because, we don't want to get into that. But I just think that there is a lot of stuff on the pipeline, and we
Certainly.
need to protect ourselves.
Mm-hmm.
But that being said,
And
like, we could do a lot of PR. Texas did a lot of really great commercials, like the state of Texas, which is very good at this. They're very good at preventing scope of practice creep. They, created a lot of commercials that they would have out there saying, I want my doctor. I want to be seen by my doctor. And this is how we educate patients. We show them the difference. I mean, there is a huge difference. So
perhaps we can find a link to one of those spots and include
Absolutely.
that in the show notes as well. And perhaps we can end this episode with a little more awareness about scope of practice expansion for the people that want to listen to this podcast, and talk about it over dinner with your friends and find out if people are aware of it, because they certainly experience it.
Absolutely.
Dr. Deshmukh, thank you so much for speaking
Thank you.
with us. I've learned a
Thank you.
lot. I'm sure our listeners
I
have
did
also
too.
learned.
I did too. And I feel thank you so much for allowing me to share my viewpoints. And I think this is a really important topic for physicians, non-physicians, patients. And I really encourage everybody to go online and check out the resources in their state, the laws that are pending. And I always recommend having a relationship with local legislators, especially if you're a physician. It's really important that they know our point of view.
Mm-hmm.
Excellent. All right.
Yeah,
Thank you so
absolutely.
much.
Thank you so much.
Yay.
Thanks for all your time.
Thank you so much. I appreciate it.
Wow. She was great.
Dr. Deshmukh is amazing. What a good conversation we've had. I've learned so much from her.
Yes. What a great first episode also.
And we're just scratching the surface on scope of practice expansion.
There's a lot of things to talk about.
Yeah. If you would like to be a guest, if you have anything to contribute on the topic of scope of practice or anything that we've talked about today, please sign up to be a guest on radcentralpodcast.com. Listen, like, and subscribe wherever you get your podcasts. RadCentral is a production of Excalibur Healthcare. From all of us here, have a great week.